Hello, good morning. And I am Kevin Albuquerque from the University of Texas Southwestern Simmons Comprehensive Cancer Center, and I will be presenting on an update on management of gynecological cancers. I would like to begin by thanking Drs. Albert Kung and Dr. Beth Erickson for inviting me today, and I also wish to express my thanks to Dr. Lily Lin for sharing some of her slides. My learning objectives are going to be on the use of image-guided brachytherapy for cervical cancer, understanding some of the limitations and benefits of intensity-modulated radiotherapy for gynecological cancers, and how to integrate chemotherapy and radiotherapy into our clinical practice. So first, let's go on to endometrial. As you're all aware, it is the commonest gynecological female cancer, and we are all familiar with the main risk factors, particularly obesity, which is increasing, diabetes, Lynch syndrome, and the protective factors like breastfeeding, smoking, and physical activity. Unfortunately, the incidence of this cancer is increasing, as is the mortality. When it comes to the histological classification, the classical way of dividing this is into type 1 and type 2. And the type 1 is the endometrioid, the type 2 is a non-endometrioid. Type 1 is associated with obesity, has a low grade, generally has a positive hormone expression, and low p53 mutations, and as well. And the type 2 is exactly the opposite. This classification is not completely inclusive of all the uterine cancers, and so requires some amount of change. Most recently, the Cancer Genomic Atlas Research Network published a classification of the molecular genetic makeup of endometrial cancer and has divided it into 4 groups as shown. The first one is the Pol E, which has most of the low-grade cancers. Second one is the hypermutated MSI unstable. The third one is the copy number low, with low number of mutations, typically the endometrioid adenocarcinomas, low and high grade. And finally, the copy number high, which includes mostly the serous carcinomas, typically having a p53 mutation, as well as some of the high-grade cancers. And you can see that the red curve does the worst as far as progression-free survival is concerned. FIGO staging is as shown in this slide and has not changed since 2009, when it was divided into 1A and B, taking out the 1C, and 3C, 1 and 2, dividing pelvic nodes and parotid nodes into 2 groups. These are prognostic. The lymphatic drainage of the female genital tract follows a definite pattern, and this is shown in this figure. A very easy mnemonic is called USA Me Lies, where the upper one normally goes to the aortic, the middle portion to the external iliac, the lower portion to the internal iliacs, and the vagina is shown upper 2/3 and lower 1/3 to the superficial inguinal nodes. Now, endometrial cancers have a correlation of grade and depth of invasion with lymph node spread. This was classically shown by the GOG 33 clinicopathologic study. And you can see on this that as the grade increases and as the depth of invasion increases, the risk of lymph node metastasis also increases. I've underlined the lower row to show you that deep invasion predicts an increased risk of lymph node involvement by 10, 20, and 30% according to the grade. So for most deeply invasive tumors, some form of lymph node assessment is required. From the GOG 33 study, there was also a clear correlation with positive pelvic nodes and the incidence of aortic, para-aortic nodes. You can see that the positive pelvic nodes were associated with a high incidence of positive parodic nodes, approximately 37%. The risk of the parodic nodal involvement is also correlated with grade and depth of invasion. And you can see over here that the grade 3 and deep invasion predicts a risk of about 20 to 25% of parodic nodal involvement in patients who have pelvic nodal disease. What is a surgical management for these patients? The classical approach for this includes total hysterectomy, bilateral salping oophorectomy, and lymph node assessment. This can be achieved by a minimally invasive approach, which is considered better for the patient. Lymph node including pelvic and parodic nodal dissection is required, especially for the higher risk histologies. This, however, is changing with the institution of sentinel lymph node biopsies. For periodic nodal dissection, typically most gynecologic oncologists will perform this to the level of the internal mesenteric artery or higher. Currently, sentinel node mapping is considered standard of care, particularly for uterine confined lower grade cancers. For more advanced tumors, serous cell and clear cell carcinomas, omental and peritoneal biopsy is indicated, as well as it is a common practice to perform detailed pelvic and periodic nodal sampling for these patients. So this study by Kumar et al. Describes the distribution of periodic lymph node metastasis. Essentially what this is showing that with ipsilateral PA nodes being negative below the IMA, there were 35% of patients who had lymph nodes above the inferior mesenteric artery. And for patients who had both above and below the inferior mesenteric artery, 53% of patients were present in this group. This indicates that about 88% of the parodic nodes are above the inferior mesenteric artery, and these are not necessarily sampled at the time of standard periodic nodal dissection. This may become less and less important as less and less patients are undergoing periodic nodal dissection currently because of sentinel node biopsy. What happens to patients with sentinel node biopsy showing micrometastasis and the isolated tumor cells, the definitions of which are given on the title of the slide. This is an elegant paper by Plante et al. From Quebec, in which study most of the patients with the ITCs did not receive adjuvant therapies. A few of them received some chemotherapy or some radiation. Despite this, you can see on this analysis that the progression-free survival of the ITCs, which are green, are almost similar to the patients with negative lymph nodes, which is red. Similarly, the overall survival was no different, indicating that ITC patients behave almost similar to those with negative lymph nodes. Micrometastasis patients did get adjuvant therapies, and their outcomes were better than the patients with node-positive disease. And in most practices, micrometastatic disease often gets typical adjuvant therapy. What are the surgical pathological risk factors for recurrence? And these are classical as shown: depth of invasion, cervical invasion, grade, type of histology, LBI, tumor size, and low uterine segment involvement. To explore these risk factors, several adjuvant radiation trials have been conducted. These are all phase 3 studies and all looked at the benefits of radiation in different groups of patients. Two of the most important ones are the GOG99, as shown over here, which was a study from the US and looked at some early, intermediate, and low-risk patients and randomized them after TAH-BSO and nodal sampling to pelvic radiation versus no adjuvant therapy. Another similar study was conducted by the European group called the PORTEC, and this looked at patients of a slightly higher risk and randomized them after hysterectomy without lymph node sampling to radiation versus observation. This often fits the model of the unstaged patients, and they were slightly higher risk than the GOG-99. As a result of these two studies, it was shown that overall survival did not change with radiation. However, pelvic recurrence was significantly impacted by radiation in the POTEC group, about 10%, and slightly lower by 7% in the GOG-99, probably because these patients had nodal dissections. This is a summary of several intermediate risk endometrial cancer phase 3 studies as highlighted initially, and all of these show that there was a benefit for local recurrence with radiation, and the benefit depended upon the risk level of the patients chosen for the study. Subgroup analysis of POTEC and GOG distilled a highest risk group called high intermediate risk group, and the risk classifications of the GOG-99 are shown on the left, including an age-dependent risk classification, and looked at three factors: grade, LVSI, and deep invasion. And for the POTEC, it included age greater than 60 and grade and deep invasion. These higher intermediate risk group patients showed a significant benefit of 19% improvement of any recurrence for the POTEC group with radiation, and a 20% benefit in local regional recurrence at 10 years for the POTEC group. With selection of patients, RT will have the greatest effect. Another intriguing discovery from this study is that the patterns of failure for these patients were mostly showing that they were in the vagina. You can see in the POTEC, 67% of failures were in the vagina, and also in the GOG-99, 2/3 of the risk of recurrences were in the vagina, thus indicating that a target of treatment, namely the vagina, could be explored for more focused and definitive radiation. This was studied in the POTEC 2 study, looking at patients that were considered high intermediate risk from the POTEC classification, and these were randomized to pelvic radiation, which was then the standard arm, versus the experimental arm of vaginal brachytherapy. This was given in high dose rate 7 gray times 3 fractions, or LDR 30 gray. One must note that this was the older FIGO staging, so therefore 1B grade 3 doesn't have the same connotation of the 1B grade 3 that we use nowadays. Though these patients were classified as high intermediate risk, they were actually predominantly at a lower risk end of the spectrum for this group, and therefore one has to be careful when interpreting the data. The findings are as follows. They show that there was no difference in the vaginal recurrence for the two arms, but there was a significant difference in the pelvic recurrence, for vaginal brachytherapy showing a higher pelvic recurrence of almost 4% compared to 0.5%, and at 10 years of 0.9% versus 6% for the vaginal brachytherapy arm. This was statistically significant. However, there was no difference even at 10 years for disease-free survival in the two arms or overall survival, thus indicating that the two arms were equivalent for vaginal recurrence. In addition, there was a significant reduction in the toxicity, as shown over here, for the vaginal brachytherapy arm, where there was a high incidence of grade 1 and grade 2 toxicity for the external beam radiation arm in this study, with a corresponding decrease in the quality of life on long-term follow-up. The toxicity of the long-term could be because of 2D techniques of external beam radiation, which cause worse side effects. So in conclusion, the risk of pelvic recurrence in this group is low. The criticism is that the population that was chosen is a lower risk population than POTEC 1. But vaginal brachytherapy was found to be sufficient for this unstaged population, as shown on the slide, and the side effects from vaginal brachytherapy are low. One must be careful in interpreting data and including patients that were not included on the POTEC classification and offering them vaginal brachytherapy alone when actually radiation by external beam approach may be indicated. There is a very important document published by Astro, the guidelines looking at early stage endometrial cancer and recommendations for radiation, and some of these are highlighted on the slide. I would encourage you to look at this document in great detail. Essentially, this is suggesting that for some patients, there is no indication for adjuvant therapy. These are the low-risk patients. Patients, however, who are so-called low risk, if they have other risk factors, namely higher age, LVSI, or if they have deep invasion, they may need brachytherapy. For patients who are grade 3 with no myometrial invasion, they could be observed or offered vaginal brachytherapy. Similarly, patients who are grade 1 and 2 greater than 50% could be offered vaginal brachytherapy or external radiation therapy depending upon the risk factors. Patients who are unstaged may benefit from external beam radiation therapy depending on their risk factors. We don't often look at the ESMO guidelines, but I'd like to highlight the ESMO risk group classification, which I would encourage you to read, and the references below from Colombo, showing that the Europeans have classified early stage endometrial cancer in a slightly different fashion. They have a low, intermediate, and a high intermediate group. The high intermediate group includes patients which are stage 1A grade 3, and also patients which are 1A grade 2 with LVSI. And they also have a high risk group which includes the old 1C grade 3, or what we would now call 1B grade 3, and also the serous and the clear cell, for which they recommend external beam radiation therapy. Another important thing to look at is LVSI, which has been classified as diffuse LVSI, being a higher risk factor for patients to have external beam radiation therapy. More about that later. So the pooled POTEC 1 and 2 data looked at LVSI because this had not been included in the risk categorization and because this was shown to be important in the GOG classification. They devised a 3-tier system for LVSI and found it to be the most reproducible, classified as no, focal, and substantial, also diffuse or multifocal seen. Substantial LVSI was found to be an independent predictor of distant metastasis and overall survival. And these patients who did not get external beam radiation therapy and got vaginal brachytherapy alone had a very high risk of pelvic recurrence, 27% compared to 4% for those who had external beam radiation therapy. The limitation from the study is that it was a small percentage of patients, and also it is difficult to get this LVSI categorization in most US centers. Another problem was that most of these patients were unstaged, and so they are not necessarily applicable to situations in the United States. I'd like to give a shout out for the nomograms from the POTEC, and you can look that up, and that will help you to categorize patients better and decide whether they will benefit from the addition of external beam radiation therapy as compared to vaginal brachytherapy if one cannot identify which category they belong to. For high-risk histologies, the best treatment includes a combination of vaginal brachytherapy and chemotherapy, though some centers will also add external beam radiation therapy instead of vaginal brachytherapy. Most of the studies are shown here are retrospective, but you can see that with the addition of chemotherapy and brachytherapy, the recurrence rates are really low. So the take-home points from so far are that the upper vagina is the main site of locoregional recurrence in early stage uterine cancer. For intermediate risk stage uterine cancer, vaginal brachytherapy alone is good, with external beam being reserved for the highest risk patients. Combined vaginal brachytherapy and chemotherapy is indicated for high-risk histologies, which are early stage. A brief point about vaginal brachytherapy. The dose specification can be at the depth or the surface. The length of the vagina is variable, though remember that in most randomized studies, the length was about 3 centimeters. Vaginal applicators can be either single channel or multi-channel. Single channels are generally good. Planning is either 3D versus 2D. 3D allows for air gap assessment, and it's especially useful for combination external beam and brachytherapy because it allows you to look at the bowel dose, which is critical. This slide is showing you the fractionation that is commonly used, and the most common fractionation is the 7 gray times 3. Another common fraction is 5 gray times 5. Also, I'd like to point out the MD Anderson 6 gray times 5 to the surface. For post-external beam radiation therapy, the common fractions are 6 gray times 3 after 45 gray, or 6 gray times 2 up to 50 gray. Another common type of fractionation is 5 gray times 2 or 3. So we don't have any interactive questions and answer sessions over here, but I thought I'd just put this out to you, and you can answer this to yourself. You have a patient who's 61 years old with a new FIGO classification of 1B grade 3 with positive LBI and negative lymph nodes, 0 out of 15. What do you want to do? Brachy alone, brachy and chemo, external beam radiation alone, or external beam radiation with chemotherapy, or observation. So this slide shows you data from POTEC cohort, which included the old 1C grade 3, currently called 1B grade 3 patients. These were not included on the POTEC 1 or 2 as they were considered high risk, if you remember the ESMO classification. And despite all receiving radiation therapy, the cumulative percentage of death was highest in this group of patients compared to the lower high intermediate risk patients. These patients all got external beam alone, suggesting that external beam by itself may not be sufficient for these patients. The role of chemo in these patients was explored further on the POTEC 3 study, which we'll be discussing shortly. So these patients should definitely not have brachytherapy alone and should all get at least external beam radiation therapy. So the risk of relapse is high. What about chemotherapy? This brings us to the first SAM question on the GOG 249 study. The GOG 249 study was a large study looking at the high intermediate risk group and some high risk patients, namely the serous and the clear cell cancer patients, who were randomized into the standard arm of pelvic radiation alone compared to the experimental arm of chemotherapy and brachytherapy. Unfortunately, it did include a mishmash of patients, and it did have only 3 cycles of chemotherapy with vaginal brachytherapy compared to the standard practice of 6 cycles of chemotherapy. What it did show that chemo and brachy was not superior to external beam radiation alone. This was an unusual result, and essentially external beam radiation was equivalent for this group of patients. Toxicities were greater with the vaginal brachytherapy chemotherapy arm as far as the acute toxicities, but the late toxicities were almost equal. So in summary, this study showed that pelvic radiation should be considered for the highest risk stage 1 and 2. There was no evidence that chemotherapy improved survival. However, there are certain cautionary points because there was a lower percentage of high-risk histology in this study. Also, there was a heterogeneous group of patients on this study, making interpretation difficult. So in practice, we still use chemo in serous and clear cell uterine cancers. And it's best to reserve external beam radiation therapy only for the high-risk patient who's unable to have chemotherapy. Going on to treatment technique. For patients needing external beam radiation therapy in the post-operative setting, the standard now is IMRT, and this is being shown in many studies to be beneficial for the patient. And most recently, we had the publication of the RTOG 1203 Time-C study looking at standard full-field external beam radiation therapy compared to IMRT for post-op setting. Some of these patients also got chemotherapy. The primary endpoint was GI toxicity from baseline to 5 weeks measured by the bowel domain of EPIC. There were a number of secondary endpoints. Standard radiation was 3D conformal, and IMRT included the clinical nodal target volume and a vaginal internal target volume, which was expanded by 7 millimeters to create a planning target volume. BMAT and tomotherapy were allowed. This is showing you the 3D CRT fields. And the outcome was that based upon the patient-reported outcome of EPIC, there was a significant poor quality of life, GI quality of life for the standard RT, which continued till week 5, but disappeared at weeks 4 to 6 after radiation. There's also a detriment for the EPIC's urinary scores for standard RT compared to IMRT, as well as other patient-reported toxicities were significantly worse for the standard radiation arm compared to the IMRT arm, concluding that pelvic IMRT was associated with significantly less GI and urinary toxicity compared to the patient's perspective. IMRT contouring is important, and that is, this is the atlas that's available for use. So IMRT contouring is important. This is showing you examples of contouring of the external and the internal iliac. One of the nodal stations that's missing on the original atlas and hopefully will be described in the newer atlas is the contouring of the obturator nodes, which also are important targets, and they generally stop at the level of the obturator canal. The ITV is an important concept that needs to be completely and clearly drawn for patients getting IMRT. You can see on this patient, in the empty bladder, the vaginal ITV extends into the bladder, and you can see this on the lateral view how much the full bladder and the empty bladder vaginal targets differ. For a distended rectum, the vaginal ITV is going to be within 1.5 cm of the posterior rectal wall. Next, we're going to go to advanced endometrial cancer, and this is applicable to stages 3. Another question which you can answer to yourself is for this patient who had 3C1 endometrial adenocarcinoma with sentinel node mapping. She had LVSI and she had 1 positive sentinel lymph node. What would you recommend for her in your practice? External beam alone, in combination with chemotherapy, or chemotherapy alone? Whatever your answer, you should include chemotherapy along with radiation, and hopefully this will become clear by the end of this presentation. An important study comparing chemotherapy to radiation was the GOG 122. This was slightly flawed because it included some stage 4 patients. Also, the patients did not have complete resection of their tumor. There was at least greater than 2 cm residual tumor left behind. And it compared whole abdominal radiation with slightly inferior doses to several cycles of very toxic chemotherapy. What it did show, however, was that based upon some stage adjustment analysis, there was a benefit for progression-free survival and overall survival for the chemotherapy arm. One of the other points that was found on the study was that the problem of locoregional recurrence was still seen, and you can see this here in the whole abdominal versus the chemotherapy arm. And this indicated that the combination of radiation and chemotherapy needed to be explored. Initially, this was done in a combination in a sequential fashion, and this is an important pooled analysis from two studies, the EORTC and the MANGO studies, and was initially reported by Hogberg. Both these studies actually had different chemotherapy types and sequences, but the outline was the comparison of external beam radiation alone versus chemotherapy and radiation in a sequential fashion. The primary endpoint was progression-free survival. The pooled analysis did show that when you had a combination of radiation and chemotherapy, there was a significantly better improvement in the progression-free survival compared to radiation alone. So this indicated that radiation and chemotherapy probably are both effective in benefiting these patients. This brings us to a SAM question looking at a concurrent chemoradiation study. And based on the premise that concurrent radiation and chemotherapy will provide most effective means of delivering these significant therapies together, the GOG 258 compared chemotherapy, carbotaxol 6 cycles, with a concurrent chemoradiation arm, which was considered experimental. The types of patients that were included mostly stage 3, some 4As, and some high-risk early-stage histologies. The outcomes were that there was no difference in the chemoradiation arm compared to the chemotherapy arm for patients as far as relapse-free survival and overall survival were concerned. However, an important finding was referring to locoregional recurrence. And you can see on these two curves, that vaginal recurrence was higher in the chemotherapy arm, as well as the pelvic and paradigmal recurrence was higher in the chemotherapy arm compared to the chemoradiation arm, a combined total of almost 30% for patients getting chemotherapy alone compared to those getting radiation and chemotherapy. On the other hand, there was a definitely higher incidence of distal metastasis for patients getting chemotherapy and radiation therapy, 27% versus 21%. So in summary, there was no difference in the overall survival or relapse-free survival with chemotherapy, radiation plus versus chemotherapy. There was higher locoregional relapse with chemotherapy, almost 30% compared to 13% for the chemoradiation arm. And in the chemoradiation arm, 25% did not receive full chemotherapy, indicating that probably they didn't get benefit of the chemotherapy. This brings us to another self-assessment question, looking at the PORTEC-3 trial and the way the chemotherapy was given in the concurrent chemoradiation arm. The PORTEC-3, or the post-operative radiation therapy in endometrial cancer 3 study, was conducted in Europe and had the same experimental arm as the GOG 258. This is a concurrent chemotherapy with tri-weekly cisplatin followed by 4 cycles of carbotaxol compared to pelvic radiation alone, which was the standard arm. The patients that were chosen, however, were different in that we had far fewer stage 3 patients and we had some more stage 1 high-risk patients as well as a few serous carcinoma patients in the study. There was no residual macroscopic tumor after surgery, which is slightly different from the GOG study, and also many of these patients did not have lymph node assessment. When finally reported recently, there was shown to be a benefit for overall survival for all patients in the study for the chemoradiation arm compared to the radiation alone arm. And you can see that the curves initially staying close together, separated after 3 years. There was also significant improvement for failure-free survival for the chemoradiation arm compared to the radiation alone arm. This was further found to be significant for patients with stage 3, both for overall survival and failure-free survival, and for the serous carcinomas of all stages for overall survival and failure-free survival. Correspondingly, there was worse quality of life in patients with the chemoradiation arm, the physical functioning and global health status, which was expected. So the summary from the POTEC 3 was that 5-year overall survival and failure-free survival is better with chemoradiation, approximately 11% improvement. This difference was not seen in stage 1 and 2 patients, particularly the endometrioid type, but it was definitely seen in all the serous carcinoma patients and in the stage 3 patients. I would like to highlight this abstract from ESMO 2019, which was a further classification of POTEC 3 patients based on molecular genetic makeup. When they analyzed patients according to the 4 groups I described earlier, they found out that the group with P53 mutations had a significant benefit from combined chemotherapy and radiotherapy, with a 5-year relapse-free survival of 61% versus 37% for RT alone. And the other groups did not have a significant benefit for the chemoradiation. This is very provocative data and needs to be explored further to see which groups can be treated with radiation alone and which groups need chemotherapy in addition to radiation. So in summary, the key points are there is a lack of survival benefit to combine chemo-RT versus chemo alone in randomized studies. There's a greatest benefit for CRT in stage 3 and serous carcinomas, and there's a limited rationale for CRT in high-risk stage 1 and 2 endometrioid cancers. This brings me to cervical cancer. As you know, it's the second most common female cancer in the developing world, 500,000 new cases worldwide, also 13,000 new cases in the US, and high mortality in many parts of the world. This is a cartoon showing HPV infection and progression to cervical cancer. And you can see here that 90% of these infections get cleared, 10% progress. The cofactors for persistence include the obvious ones: smoking, HPV type, immunosuppression, which is commonly seen nowadays with patients on transplants, inflammation, and hormones and genetic factors. The common HPV types that are responsible are 16 and 18, and also less responsible are 31 and 45. The histology is mostly squamous, and 10 to 15% have adenocarcinoma, which behaves worse. Staging and workup should be highlighted by the new FIGO staging, as shown on this slide over here. This has been completely overhauled to include complex imaging and recognizes also the importance and prognosis of lymph node involvement. For the first time, lymph nodes are recognized in the staging system as prognostic. This is a summary of the stage changes. I want to highlight the fact that for stage 1A, horizontal spread is no longer part of the definition. For stage 1B, it's divided into 3 subgroupings of B1, B2, and B3, with B3 being the form of B2, and B2 namely 2 to 4 centimeters, a group in intermediate between B1 and 3, for which probably there's a benefit for radiation alone. Stage 3, of course, is the lymph node stage, 3C1 and 3. We all very well know that lymph node involvement increases with stage, and the classic increase is shown on this column here with an increase from 15 to 30 to 45 based upon stage 1, 2, and 3. There is a corresponding increase in the percentage of paralytic lymph node metastasis by 10, 20, and 30, which increases with stage. These numbers are important to remember because one needs to be able to target all these lymph node sites if indicated. Determining the extent of the primary tumor, pelvic staging examination is not extremely accurate compared to imaging. You can see on the MRI, the accuracy is as high as 86%. The MRI is superior to CT for detecting uterine body involvement, parametrial invasion, and also very superior for detecting vaginal extension, especially submucosal vaginal extension. I have here an example of an MRI from a patient of mine showing you the disease from the cervix, and the arrows indicate the tumor growing into the vesicovaginal space. You can see this on the lateral view here with the arrows. This indicates areas that need to be targeted more accurately, more precisely, and also indicates the need for possible interstitial if the patient doesn't respond. This is a slide showing you the patient with paralytic lymph node metastasis on PET scan, and this patient obviously is at a poor prognostic criteria and will need extended field radiation therapy. Now, the impact of nodal involvement is clearly shown with assigning PET staging for these patients. And this is a study by Kidd from 2010 showing a large group of patients with cervical cancer that underwent pre-treatment FDG PET lymph node staging. And you can see, looking at the disease-specific survival, it was the highest for patients without any lymph node metastasis and was not good for patients with pelvic node metastasis, but was even worse for paralytic nodal metastasis and even worse for supraclavicular. For early stage cervical cancers, the treatment is often surgical. The stages that are 1A and 1B1 can undergo surgical staging, and the typical operation that's performed is a modified radical hysterectomy or a radical hysterectomy. And this slide shows you the structures removed in each of these operations. There was a very important study that was recently reported at the end of 2018 looking at minimally invasive surgery, namely laparoscopic and robotic, for cervical cancer early stage. And this was reported by Ramirez et al. In 2018, and it showed that for patients who had open surgery compared to minimally invasive surgery, there was a reduced overall survival for the MIS group, and similarly there was a higher locoregional recurrence for the MIS group. This resulted in a recommendation not to use minimally invasive surgery for early stage cervical cancer patients, and these patients should undergo open surgery only. Now, this little table highlights the treatment recommendations by stage for cervical cancer patients, and I think it's useful for you to consider this for your study. Importantly, for the 1A2 modified radical hysterectomy, 1B1 radical hysterectomy, and for the patients who are 1B3 and 2B to 3, generally they undergo definitive chemoradiation with brachytherapy boost. What happens to patients who are early stage? Can they undergo surgery versus radiation? This was an old study conducted in Milan by Landoni and looked at a large group of patients which were clinically resectable and randomized them to radical surgery versus definitive radiation. You will note that many of the patients who had radical surgery also had adjuvant radiation therapy, And what they found at follow-up, long-term follow-up, that there was no difference in survival or local control for patients in these two arms, indicating that for early stage cancers, both approaches are equivalent. However, the patients that had adjuvant radiation therapy in addition to surgery had a higher rate of complications. And therefore, if it is clear in the beginning that a patient will need adjuvant radiation following surgery, then one should consider performing definitive chemoradiation alone for these patients to reduce the symptoms and toxicity of combined dual modality therapies. For patients undergoing curative surgery, there are certain indications for adjuvant radiotherapy. The group that is called the intermediate risk group, namely the lymph node negative group, was studied in the GOG 92 study, and this was classified by the so-called SEDLIS criteria, describing it in the next slide, but the randomization was radiation compared to observation. The SEDLIS criteria are shown on the slide and include a combination of lymphovascular invasion, stromal invasion, and tumor size. Simplified, you need 2 out of 3 factors, namely lymphovascular infiltration, at least middle, third, and greater deep of invasion, and clinical tumor size greater than or equal to 4 centimeters. So when we analyzed by these groups, it was discovered that at long-term follow-up, there was a significant improvement in progression-free survival with a 46% reduction in hazard ratio. Overall survival was not impacted, and there was obviously greater toxicity with patients who had radiation. What was more important was that the adenocarcinoma group had a significant benefit for progression-free survival with radiation compared to observation. What about the higher risk post-op group? This was studied with the addition of chemotherapy to radiation compared to radiation alone. And this study is called the Peter study. And the risk factors that were included in the high-risk group include the 3 Ps, the positive margins, positive lymph nodes, and the perimeter invasion, and randomized them into radiation alone compared to chemoradiation. This chemoradiation was slightly different in that it included 2 cycles of 5-FU and cisplatin during the radiation and 2 cycles after the radiation in an outback fashion. And this was the first time that outback chemotherapy was used. The results are shown over here. There was a significant benefit for progression-free survival, as well as a significant benefit for 4-year overall survival of almost 10% greater. It was not possible to determine the impact of outback chemotherapy in this study. For locally advanced cervical cancer, surgery is not possible, and the treatment is definitive chemoradiation. I want to show you this image of a 42-year-old patient with a large cervical squamous carcinoma extending to the lower third of the vagina, and the arrow is shown over here, and invading the rectovaginal septum on pre-treatment T2-weighted MRI. So the question, unfortunately, is not interactive, but you can answer it to yourself, is how would you treat this patient? Would you do concurrent chemotherapy with a tandem and ring brachytherapy? Would you do neoadjuvant chemotherapy followed by surgery? Would you do concurrent chemoradiation with interstitial brachytherapy? Or do you do neoadjuvant immunotherapy followed by concurrent chemoradiation? And hopefully these answers will become clearer as we progress in this presentation. So for definitive chemoradiation, we had 5 landmark clinical trials that showed an improvement in overall survival and local recurrence for chemoradiation with cisplatin compared to radiation alone. And this is from a clinical alert from the NCI recommending chemoradiation for all patients with advanced cervical cancer. These are some of the studies, the GOG 120, the GOG 123, which showed an improvement in overall survival, which was significant, as well as in local recurrence. The Canadian study did not show significant, statistically significant benefit, and there were several reasons for that. I'd like to highlight the RTOG 9001, which is one of the other studies that showed a significant benefit for chemoradiation. This was a unique study that it included radiation compared to chemoradiation, and it included patients who was 2B and 4A. The radiation that was given was extended field radiation, and the chemotherapy was cisplatin and 5-FU. It showed that at 8 years, there was a significant benefit for overall survival, almost a 24% benefit. There was obviously a benefit for overall survival by stage grouping, and there was a significant local regional recurrence benefit survival, almost 13 to 15% for stage 1Bs and 2s, as well as for stage 3s and 4As. There was a meta-analysis of chemoradiation studies that was conducted, and they looked at patients who had chemotherapy plus radiation versus radiation. There was an 8% absolute improvement in disease-free survival and an overall survival benefit of 6% for all combined studies. However, when we looked at patients who had chemoradiation plus additional chemotherapy versus radiation alone, and there were only 2 trials of this type, so obviously the numbers are limited, there was a 19% absolute overall survival for these patients, indicating some benefit for outback therapy. The role of outback therapy was studied in this Argentinian study with Duenas Gonzalez. This study included patients who were advanced cervical cancer and included standard chemoradiation with brachytherapy, and compared that with intensified chemoradiation followed by intensified outback chemotherapy. This was kind of a problem with the study in that it included both intensified therapies during the radiation as well as after. Because of the combination of cisplatin and gemcitabine, there was a significant improvement in progression-free survival and overall survival, but also a significant associated toxicity rate, almost doubling of the grade 3 or 4 toxicities and almost a tripling of the hospitalizations for these patients. So it was very hard to determine what was the important component of the study. Was it the intensified chemotherapy or was it the outback therapy? There has recently been completed an outback study looking at patients who had additional carbotaxol following standard chemoradiation, results of which are awaited. I want to bring to your attention this study from India called by Gupta et al., looking at neoadjuvant chemotherapy and surgery versus chemoradiation. Because sometimes you may be faced with a situation where your surgeon wants to do surgery for advanced cervical cancer. And this study showed conclusively, it compared chemotherapy plus hysterectomy versus chemoradiation. There was a detriment in the disease-free survival for patients who had surgery, but there was no difference in the overall survival. So for advanced cervical cancer patients, the combination of treatment should include external beam radiation therapy, boost to the parametrial sidewall or nodes, brachytherapy along with concurrent cisplatin, typically 5 to 6 cycles. The radiation fields are as shown for pelvic radiation. I also want to highlight the role of PET and CT fusion for patients. This is a particularly difficult case for a patient who has a large mucinous cervical cancer along with a large fibroid. You can see this on this side, and it was difficult by standard CT to determine where the tumor ends and where the fibroid begins. This was possible on the MRI, and I also included part of the fibroid in the target because it was slightly PET avid on the PET scan. So combination of PET, MR, and CT produced the final CTV. So you saw the patient I just presented, and you cannot selectively treat different targets with 3D. Therefore, IMRT is important. Use of IMRT for intact cervix has some controversies, particularly for contouring, organ motion, simulation setup, and IGRT. That brings you to your next SAM question. for IMRT for cervical cancer, based on the guidelines from the GYN IMRT Consortium, please define the CTV. This is the paper I was referring to by Karen Lim et al. And this slide shows you the CTV for cervical cancer. The table shows you the components for the CTV. Accurate target definition is vitally important for definitive treatment with IMRT, as unlike 3D, IMRT is not forgiving. And the definition of the clinical target volume includes structures that are surgically removed in the radical hysterectomy. This slide shows you the different components of the CTV, including the parametria, the cervix, the uterus, and the vagina. It's important when you're planning your IMRT to include an ITB component, and this is one patient showing the shift of the position with the bladder full and the bladder empty, and indicating that there is a large volume that needs to be treated to traverse the target movement of the uterus in the cervix. So for intact cervix, you should always use bladder full and bladder empty, use a pre-treatment MRI, use all available imaging. I would often use my PET CT, my planning CT, as well as the MRI to provide a composite ITB for the cervical and the uterus. In addition, there should be large margins for the primary CTV, and then the PTV margin is approximately 7 millimeters. Daily soft tissue IGRT is often needed and recommended, and replanning may be needed at short notice because the motion of the cervix can exceed 2 centimeters in some situations. So then why do IMRT? There are certain advantages to IMRT, and these include advantage of sparing bowel, kidney, duodenum, inguinal nodes, sparing the femurs. You can do an SIB boost. You can do sidewall boost. Also, there's potential reduced bowel, bone marrow toxicity, and from most recent publications, some potential reduction of pelvic fractures. Periodic lymph node contouring involves careful contouring of these structures around the vessels. This is a paper by Takier et al. Showing the mapping of these lymph nodes. The new NRG Atlas coming soon will demonstrate how to contour periodic lymph nodes. I have an example of a patient from my practice showing that at the level of the hilum and above the hilum, since the nodal metastases are rarely seen to the right of the IVC, we often split the IVC and try to spare some of the kidney on the right side, most of the lymph nodes being present on the left side of the aorta. So the key points is concurrent chemoradiation remains the standard of care for locally advanced cervical cancer. IMRT may be appropriately selected situations, and use of all available imaging is required to define the uterine cervix and the ITB. So now we move on to brachytherapy for cervical cancer, which is often high dose rate brachytherapy. Brachytherapy is an extremely important component in the treatment of cervical cancer treatment, and you can see in the study by Carlson et al. That the addition of brachytherapy to external radiation therapy dramatically improved the overall survival of patients compared to those getting external radiation alone. Brachytherapy is a continuous process. You have to plan from the beginning and strategize. The tumor mapping is done at initial examination. Any disease that's involving the lower vagina or outside the main organs may preclude standard HDR intracavitary brachytherapy. And the patient I presented before would have been a candidate for interstitial brachytherapy. So plan ahead from day one for interstitial brachytherapy if needed. If intracavitary brachytherapy is possible, then is the organ anatomy favorable? Think ahead about the applicator you're going to use. If it's a Tenorman ovoid, Tenorman ring, or Tenorman cylinder. If the uterus is anteverted or retroverted, make sure you look at that on the pre-treatment MRI or CT scan. Look at the vaginal fornices to determine what size ovoids to use. And finally, look at the tumor anatomy. Is it favorable? Is the os difficult to visualize? Will the tumor size fit in the prescription isodose? If not, interstitial hybrid brachytherapy is indicated. There is a strict timeline for advanced cervical cancer treatment, and this starts from day 1 and should get completed within 6 to 8 weeks. This requires a lot of planning and teamwork. As you can see, the first brachytherapy, planning for your MRI, the CT, and teamwork is therefore required to produce a perfect symphony, playing all the notes in time to finish on time. There was a study from the RTOG database by Dr. Viswanathan looking at quality of brachytherapy and showing how that matters. It's important to look at the symmetry of the ovoids in relationship to the tandem and relationship to the flange. Look at the packing, as all these factors, particularly packing proximal to the ovoids, will impact the overall control rates of the tumor. More recently, we have MR guidelines for MR brachytherapy by the Vienna group and the Gynecologic group. They've defined the GTV, the high-risk CTV, and the intermediate-risk CTV based upon different dose levels for these parts of the tumor. This slide shows you the figurative descriptions of these different targets and should be studied carefully in order to perform good MR-guided brachytherapy. There's a document called the ICRE 89 that encompasses all of these elements, and I strongly recommend that you look at this document and study it in detail. There may be a role for CT contouring of brachytherapy, and as shown as in this paper, this was only beneficial for patients with smaller tumors without extensive parametrial extension. For the most part, MRI gives you the best visualization of the cervical tumor. The doses that are commonly recommended are shown for larger tumors 6 gray times 5. For smaller tumors, you can do 5.5 times 5. For large tumors that are not covered by the standard pear-shaped distribution as seen on the left-hand panel, you would have to use some kind of hybrid applicator with needles, which would make this pair slightly abnormal to cover this area. So when I see a patient for brachytherapy, at the first instance, I'll look for bulky tumors, asymmetrical tumors seen in the left panel here with a very asymmetrical posterior lip, thick vaginal involvement, which indicate that this may not be covered completely by an intracavity approach. And if needed, I will obtain an interim MRI and then assess for intracavity coverage. And at the first implant with MRI done, I'll then assess the HRCTV volume and then determine whether you need to use a hybrid interstitial approach. This is showing you a patient who had a very bulky posterior cervical tumor, which was not covered by classical intracavity approach, and therefore we had to introduce needles to cover this appropriately. The Gynecologic group has produced planning and limit constraints for brachytherapy for cervical cancer, and the most recent guidelines have been presented in the EMBRACE-2 study that's still ongoing and is divided into planning aim constraints and planning limit constraints. Essentially, you should aim to get your tumor doses within this range, but avoid limiting the tumor doses to these ranges. So essentially, you have to have at least an 85 gray for the tumor, none less than 85 gray, and you have to have the 0.8 dose at least greater than 65 gray. For the different OARs, there's been a tightening of some of the constraints, with the rectal D2CC now being aimed to be 65 gray and less, and the bladder D2CC aimed to be 80 gray or less, when formerly it was 90 gray and 75 gray. Another interesting recommendation is for the rectal vaginal point to be 65 gray. Results of image-guided brachytherapy are excellent. You can see on these several series with very low late toxicity. This panel shows you some data from retro-embrace and showing you 3 curves based upon the dose to the D90 of the target. And you can see as the tumor volume increases, you need a higher dose of up to as high as 95 gray to bring about a 90% control rate. Additionally, if you perform adaptive brachytherapy without hybrid applicators, there is a 10% reduction in the local control for patients who have just simple adaptive compared to patients who have hybrid applicators. This is a pictorial representation of the dose levels by the JEC-Estro, the GTV, the HRCTV, and the IRCTV getting at least 60 gray. So moving now to vulvar cancer. This is the crash course, and I'll briefly describe the management. So vulvar cancer, the physical exam, essentially make sure that you look at the tumor, whether it's well lateralized, analyze and examine vagina, cervix, perform a digital rectal exam. Imaging should include, if possible, MRI at least, and PET scan if indicated for advanced patients. Biopsy is always required if there are palpable lymph nodes, a fine needle aspirate, and for vulvar cancers, tumors, do an incisional biopsy followed by the appropriate treatment if indicated. That incisional biopsy is important for detecting the depth of invasion. This is showing you the staging system, which has not changed, and it's still complicated. Essentially, what I'd like to point out here is the stage T2 and T3 tumors are already fairly advanced, and most of these tumors typically are not surgically resectable. When I say that tumors are not surgically resectable, I would like to refer to so-called functional resection versus non-functional resection. So functional staging includes patients who are early stage, can be treated with surgery without disturbing too much of their function. For those patients, the type of surgery that is done is a wide local excision or a vulvectomy, and adjuvant radiation may be indicated based upon the findings. For a locally advanced disease, when they have extensive disease, ultra-radical extentrative surgery is still possible, but that results in tremendous loss of function and is not recommended. The surgical modalities are as shown, often requiring a radiotherapy and chemotherapy. The risk factors for vulvar recurrence are well known, including tumor size, multifocal disease, margins, and stromal invasion. This study by Dr. Viswanathan shows you the benefit of dose and control of recurrences following surgery according to margin status. Patients who had doses of greater than 56 gray did better. Patients who had less than 56 gray. Hence, the recommendation for radiation after primary resection is generally 56 gray for close margins and 60 gray for positive margins. For the groins, there's an old GOG study that looked at radiation compared to surgery. This was faulty in that it didn't have proper CT planning and only included low energy electrons. So the findings for patients with node-negative disease who had groin dissection showed a 0% recurrence compared to a 18% recurrence for the radiation arm. And the conclusion was that RT could not control clinically negative disease. However, this was faulty because of the planning, and shown on the slide, you can see that the median depth of the lymph nodes is typically 6 centimeters, and they were grossly underdosed. In the modern era, most patients will undergo sentinel node biopsy if they have T1, T2 tumors less than 4 cm and greater than 1 millimeter depth of invasion. This was the groins V1 study, which randomized patients into sentinel node biopsy if they were negative and no further dissection versus inguinofemoral lymph node dissection. And what they showed was that 5-year isolated groin recurrence was 2.5% if sentinel node was negative. There was a considerable increased toxicity from completed nodal dissection, including wound breakdown, lymphedema, and cellulitis. For patients who have positive nodes on dissection, there was a study by the GOG comparing ipsilateral pelvic nodal dissection compared to pelvic and groin radiation. And that study reported that patients who had more than one node had the best benefit from radiation after groin dissection, where the groin failures were reduced from 23.6 to 5%, and the pelvic failure rate was almost equivalent. There was no overall survival benefit for patients with one nodal positive, so the recommendation is therefore to treat only patients who have more than one node or have clinical N2, N3 groin nodes. Longer-term follow-up showed that patients with lymph node ratio greater than 20% did the worst following surgery compared to radiation. So for adjuvant radiation therapy for nodes, these are the following dose recommendations. Typically 45 to 50 gray if there's no EC and negative radiologically. You can give a higher dose if they're slightly enlarged. For ECE, give a dose of 60 to 65 gray, and for gross residual nodal disease, 60 to 70 gray. These are the key points in the management of the groins. Typically, completion node dissection if sentinel node biopsy positive, and adjuvant radiation and concurrent chemotherapy for greater than one positive node. If patients have positive sentinel node with no further dissection, consider appropriate volume-defined radiation and chemotherapy. This is the basis for the groins V3 study. What do you do for patients who are surgically unresectable? There are several GOG studies, and this is the GOG 205 study, which is a phase 2 study looking at higher doses of radiation and weekly cisplatin, followed by biopsy or surgical resection. Out of these patients, there was a 50% PCR and a 65% CCR in this group of patients. I'll highlight here this table from the GOG studies showing you the significant improvement in the control rates depending upon the doses of radiation and the chemotherapy. For the most recent study, you can see there was a bump by 20% in the PCR and a 15% bump in the CCR. For the most recently, there's a currently ongoing GOG study looking at advanced vulvar cancer called the GOG 279. And this study is hoping to improve upon the results of the GOG 205. And as I mentioned, the dose of the radiation is being increased to 64 gray for gross disease, along with more intensive chemotherapy, gemcitabine and cisplatin. So intensified radiation, intensified chemotherapy, with the aim to intensify the results of this definitive chemoradiation therapy. And the goal here is to bring this pathological complete response to 70%, which is a 20% bump from the previous GOG 205 study. So stay tuned for the results of that study. For primary treatment, therefore, based upon recommendations from the latest GOG study, the dose should be as high as 64 to 68 gray. For nodes that are not resected, it's the same dose. For massive fixed nodes, the dose should be 65 to 70 gray in fractionated doses along with chemotherapy. Treatment technique is important and should include very detailed simulation. I like to use a frog-leg position to avoid overlapping regions of skin, mark the scars and the tumor with sticky wires, use markers in the rectum or the vagina depending on which organs are involved, and you can use a bolus or you can use a custom 3D bolus. The fractionation that's used is typically 1.8 to 2 gray SIB IMRT. The SIB is used for the pelvic nodes that they are metastasized. Generally, a mild hypofractionation is used for the nodal boost. It's recommended to use a virtual PTV to get the dose to the skin. This means making sure that the PTV of the vulva extends into the bolus or outside the skin to get a good dose to the skin surface. Always use TLDs to check the skin dose. Typically, radiation for vulvar cancers is given using IMRT. This is shown on the right-hand panel. IMRT has significant advantages of sparing the bowel, femoral heads, protection of the skin outside the PTV, reduced acute and late toxicities. Disadvantages is that it's a steep learning curve, and there are some controversies about target delineation and daily setup. So this brings us to the next SAM question about contouring of the groin nodes. So how much margin is required for inguinal nodal contouring? This is a study by Kim et al. From Pro 2012, which showed that in their study, in order to encompass 90% of the positive nodes, they needed a significant 2.5 to 3.5 centimeter margin around the vessels, except posteriorly. And you can see it on this slide over here. This is an example from a patient from my practice showing you the inguinal nodes and how it should extend from the pubic tubercle all the way to the lateral muscles and include considerable portions of the subcutaneous tissue. There was an excellent consensus contouring guideline for vulvar primary published by the NRG by Dr. Gaffney in 2016. And this is showing you a summary contour from all the experts of the vulvar CTV, a locally advanced case, including the groin nodes, and the postoperative vulvar carcinoma, which includes the CTV plus a 2 cm margin if required. This is a summary of the recommendations for locally advanced vulvar cancer, and this is important to break it up as shown. For the primary, the CTV should include the entire anatomic vulva. If the GTV extends beyond the vulva, you add a 1 cm margin. Adjacent organs require to be included as separate components of the CTV. So therefore, if the vagina is involved, you include the gross disease and 3 cm of the vagina, or the entire vagina if uncertainty. For the anus and the anal canal, you include the gross disease plus 2 cm of the anus. For periurethral, gross disease plus 2 cm, and periclotoral the same. This is an example of a patient who had a tumor that was abutting the anal sphincter and invading slightly the anal sphincter, making it a T2 carcinoma. This is shown on the contrast MRI. You can see the enhancing area. And therefore, for this patient, I've highlighted different aspects of the vulvar CTV. You can see the anatomic vulvar CTV, which is in dark orange, which includes the whole vulva on this slice. Then the GTV, which is drawn in pink, which is abutting the anal sphincter. And then the margin around the GTV with an added 1 cm as per the NRG atlas. And because the anus is involved, I included also 2 cm of the anus. You can see this on the lateral view here in blue. And also because it was abutting the vagina, I included 2 cm of the vagina. So the composite CTV includes these structures as well as the entire vulva as well as the margin around 1 cm. And therefore, this entire vulva CTV will be included as a target and then given an additional margin for PTV to cover this whole area to encompass the target. And therefore, making sure that one doesn't miss the tumor or the tumor extensions. So the key take-home points from this are the treatment of vulvar cancer requires multidisciplinary management and individualization. There are separate treatment indications by primary and nodes. So you break it up into treatment indications for the primary and treatment indications for the nodes. IMRT can reduce acute and late toxicities and achieve tumor control, but must be used very carefully. So thank you all for participating virtually and being a part of this new experience. Please stay healthy. If you have any questions, please feel free to email me, and my email is attached. Take care.